So Joe Ott, CPA, has served in the healthcare industry since 1991 by providing financial statement audit services, Medicare and Medicaid strategic consulting services, corporate integrity services, and strategic positioning services to a variety of healthcare organizations. Steve Smith is a member of the Healthcare Performance Improvement Practice Unit and serves as the practice unit's lead for rural hospital performance improvement. Please keep doing that. And he has provided consulting services to hospitals, physician practices, rural health clinics, FQHCs, and other provider groups related to revenue cycle performance, RHC establishment, operations, and compliance. All right. Joe. I forgot the CPPs.
All right. Thank you very much. You got it. That's my problem. I'm very loud, and I get a lot of attention. Just like you all were connecting with each other here a few minutes ago and introducing each other to each other, and I think that's great. Steve and I are excited about the opportunity to have this discussion with you all this afternoon. And, you know, one of the things that we all know in the healthcare industry, it's easy to navigate. Okay, so you're still with me. Good. I like that. You know, the healthcare industry is anything but easy. And, you know, with the government shutdown, with OBBA happening, the Medicaid cuts, tariffs, also regulatory issues, there's a lot of challenges in the healthcare industry. And one of the things that organizations are doing right now is really looking at how is that going to impact my margin? How is that going to impact our workforce? How is that going to impact the individuals in the communities that we serve? You know, I was looking at the most recent Kaufman Flash report, and recently, in the last, 9 months prior to July, we were seeing margins increasing. We were seeing upticks in those operating margins. In July, though, they decreased. They declined slightly. And so what does that mean? That means organizations are thinking about what are some of the impacts that are going to happen, what are some of the changes that they need to make operationally in order to take care of the patients in their community. We're already seeing individuals that are going to be, or that are being uninsured, and we're seeing increases in revenues, we're seeing increases in patient volume, but what else are we seeing? We're seeing increases in bad debt, we're seeing increases in charity care. Is that a fair statement? I see heads nodding, but no arms in the air, so okay, that's fine. Secondly, what are we seeing with expenses? Expenses are going up. Non-labor expenses, workforce expenses, those are going up. So all of those things are putting pressure on operating margins. All of those things are challenging healthcare organizations to operate at their higher level, at the highest level. Operating on all 8 cylinders is what I like to call it. Because if you're not operating on all 8 cylinders, there's going to be an issue that you're going to have to face that may not be one of the issues that, or some of the decisions that you're not going to want to make. So with that being said, a lot of healthcare organizations are going back and looking at their strategic plans and saying, okay, we need to really refocus on our strategic plans and understand what we're facing, how we're going to deal with that, and then what decisions we're going to make and how we're going to support the decisions that we do make. And so today we're going to talk a little bit about, why is data important to healthcare organizations? What are those things that you're going to have to make sure that you're looking at in order to make decisions in the future? We're also going to talk about some of the key performance indicators, some dashboards, and then really talk about some case studies and see what other organizations are doing as it relates to addressing some of the challenges. And I'll even put out there some opportunities healthcare organizations, need to take advantage of in order to survive in the future. My name is Joe Watt. I'm a healthcare partner. As the introduction said, not going to spend a whole lot of time on our slides here or our pictures here, but one of the things that I did want to share with you all, I thought it was interesting that Catherine brought up, what do you think about when you think about organizations that perform at the highest level? What I heard is I heard Costco, I heard the Ritz-Carlton, I heard Disney, right? And a lot of the way that those organizations are measured is by their Net Promoter Score. And what does that mean is basically how many of your clients and how many of their clients would suggest them working for or utilizing those services. And one of the things that we're most proud of at Forvis Mazars is our Net Promoter Score is 88. That's higher than Costco. That's higher than Netflix. That's higher than the Ritz-Carlton. And it's quite a bit higher than a lot of other professional service firms. So it's something that we really take notice to, and I appreciated, Catherine's comments about, making sure that you're providing the highest and best quality care to the communities and the patients that you serve. So why does data matter in healthcare? Well, let's think about what's happened over the last 5 years. If we think about what we've gone through over the last 5 years, prior to the pandemic in 2019, we had people, we had organizations kind of testing the waters as it related to value-based care, volume, and what would that mean if we changed from point-and-click service type service or payment rates and started thinking about volume, value-based care. People were putting their toe in the water. And then in 2020, we had the public health emergency, we had COVID-19 hit, and everything shut down as it related to value-based care. And so organizations had to make a shift here. They had to really start thinking about, how do we survive? What are the operational and financial stresses that hit the organizations in 2021? And so organizations were just putting out fires. And then also in 2022, you had, somewhat of a little bit of a crisis here where, the financial performance came down, organizations were laying off workforce, couldn't find workforce, costs were up, and there were continuous looking at or continuous operations that they had to continue to look at and make sure that, is it operating at the highest and most effective way? You get to 2025 now, and we have the government shutdown, we've got OBBBA, and we've got a lot of things that are going to hit us or that are projected to hit us in the future that's going to have significant impact on finances. One of the things that I will mention here, that if you go back to 2019 and you look at the hospitals in the U.S. that were struggling in 2019, what do you think those hospitals are doing in 2025 right now? Merged, that's an answer. What else? Closed. What else? Struggling. There's 759 hospitals in the U.S. that are struggling. About half of those are basically struggling to the point that it's not imminent closure, but very close to it. Meaning their stats, their days cash on hand, not a lot of days there to help them survive. So that is one thing that, it's interesting to me. You look at 2019, you look at 2025, very many of those hospitals are still struggling. So what do we got to do here? We've got, rising costs are definitely things that make data matter. We've got to look at some of the things where we have shrinking margins, we've got regulatory pressures, and then there's a lot of the things that, you need to look at financial performance, not only in historically what's happening, but also in real time. And then you got to make sure that you have a pulse on that, and how are you measuring that on a regular basis? We all know that the OBBBA, Medicaid financing, it's going to cost us $1 trillion. And so, you start looking at that, and it's going to impact us over the next 10 years. And that's something that healthcare organizations need to play in and pay attention to and project out or forecast out. How is that going to impact your organization? And what data are you going to use in order to project that? And then what are you going to do about it operationally in order to combat that? One of the things that is going to be interesting to see is, approximately they're estimating 10 million more uninsured patients because of OBBBA. And right now there's about 27 million individuals that are uninsured. That's going to go up to about 37 million. And so what does that mean for organizations and their revenue cycle practices? What data are you going to have to look at in order to evaluate the impact of that? And then also, what data and what metrics are you going to use in order to track this so that that doesn't have as high of an impact to your operations as maybe others would be impacted? Obviously, there's the Rural Health Transformation Program. That's great, and I think it's a great thing that they're putting $50 billion back into the rural hospitals, because many of the 759 that I mentioned before are in the rural area. But if you think about it, there's a gap between the 50 and what is projected to happen of about 137. So we have a big gap in what the impact of OBBA is going to be and what is being put back into the rural marketplace to help those hospitals offset that. And so how is that going to impact healthcare organizations? What are you going to do as it relates to the data that you're going to look at and how you're going to measure yourselves in order to minimize the impact of the margin impact here? And we can talk about eligibility requirements, we can talk about financial requirements and things like that, but at the end of the day is, as individuals become more and more uninsured, what are the things that you're going to have to do within your four walls in order to minimize the impact of that uninsured increase? And how can you find other ways for those patients to get paid for? Here's an overall timeline of some of the impact of the OBBBA. And so I'm not going to go over these, but I think that's important to think through. It's not immediate, and so we have time to address some of these things as providers and hospitals and health systems, but you got to start now. I've talked to multiple CFOs here recently, and all of them are trying to model out what this is going to do to their organization and how that is going to change some of their strategies within their strategic plan on a go-forward basis. Some of the things that we like to look at when we look at financial dashboards, you can look at financial dashboards as it relates to, current versus budget. You can look at it from prior year to last year. But one of the things that you have to make sure that you're taking into consideration is what happened during those times. One of the things that we're seeing right now is, we have a rural health clinic, for example. Rural health clinic, their costs per encounter may be going down, and they're not meeting their, maximum rate. Well, why is that? Well, partially because when did they set that max rate? They set that max rate back in 2020 during COVID. So their costs were a lot higher back in 2020 than they are today. So why isn't that rural health clinic meeting that max rate? That could be part of the issue. Their costs have changed. They don't have as high as costs. And that's just one example. So when we look at dashboards, when we look at metrics, we got to make sure that we ask the second, third, fourth question to make sure that we understand the environment as it relates to those metrics. Obviously, operational dashboards, as you heard from Les, he does a lot of operational dashboards, and so this is important. What are your ratios as it relates to labor? What are your ratios as it relates to, just operating costs to total margin or to total revenue? What are your non-labor, your labor? What are your salary benefits or your benefits as it compares to salaries? What are all those things, and how is it impacting your operations? And then clearly the revenue cycle, there's a lot of metrics as within that cycle and that process that have to be measured in order to make sure that for all the services that hospitals are doing, that you're getting paid for that. I was talking to someone else earlier, cash is king, right? Well, cash is king if you can collect it and put it in the bank and then use it for the hospital and the health system's operations. And so as we think about on a go-forward basis, we are going to show you some dashboards. We're going to show you some examples and so forth. And some of them may not be for you. And some of them may be too busy. Some of them may not hit the drivers that help your organization work. And one of the things that we just want to make sure we talk about today is what are those financial metrics that help your organization drive? And how are you measuring those on a regular basis? Because if we say that the same metrics apply for a PPS hospital as a critical access hospital, what are you going to tell me? Yes, no, maybe. I'm crazy. I've been called a lot worse. Point being is that there's certain metrics that can help organizations drive their business, and if you monitor those and you pay attention to those, that's going to be the thing that organizations are going to be able to capitalize on in order to be successful in the future. And I think sometimes it's always disheartening for me when I have conversations with hospital CEOs and CFOs, and they say, well, we didn't know this was going on. I'm like, wait a minute. This metric is something that drives your business, drives the growth in your business, and so therefore, how did you know it wasn't going on? And again, hindsight's 20/20, but still, I think it's really important that we make sure that we're looking at those stats and those metrics that help our organization drive. Again, I think there's, we can talk about real-time monitoring, we can talk about looking back historically. So I think there's benefits of both, and I think looking at an actual, monitoring, which is real-time versus retrospective, each one of those plays a role within an organization's metrics and the way in which it drives business. But I think you need to make sure that you're monitoring each one of those in the right areas. All right, I'm going to let Steve talk about some key performance indicators.
Thank you, Joe. Thanks, everybody, for being here and allowing us to be with you this afternoon. I'm going to say something that no consultant is ever supposed to say out loud in a large room. There is no industry benchmark that should ever be treated as gospel in terms of KPIs. Yeah, you just heard a consultant say it. There is never going to be a KPI that is going to be sole and true and gospel for every organization that looks at metrics related to that KPI. Now, that's not to say that they're not important. There's a very big distinction between the two. KPIs are absolutely important. They give us that true north. They give us that North Star to shoot for. But we know we have intricacies within our organization. We know we're staffed different than our neighbors. We know we're a different type of organization, like Joe mentioned, from our neighbors. All those things go into it. And so you can't just sit down and say, well, your days cash on hand are 5 days below industry metrics, and so you must be doing a poor job. Well, hang on. Do I compare that to that industry benchmark, or do I compare that to my own benchmark from this time a year ago, 2 years ago, 3 years ago, getting back before COVID? You can't just take that 60,000-foot view, and say because you're at this and the key performance indicator says you should be at this, you're doing a poor job. There's always more to the story. There's always a story to tell, and there's always details that have to be drilled into to determine, are we being successful or are we not? Now, we may still have our long-term goal be that KPI, but we may also know it's going to take us 6 months to get there. It's going to take us a year to get there because of where we are right now. All that has to be taken into consideration anytime that we talk about KPIs. Everyone here likely knows what a KPI is, but basically, we're just trying to find some level, some metric that we can utilize to say, okay, what areas of opportunity do we have as an organization? What areas are we succeeding in as an organization? Again, compared to these industry benchmarks. But what's even more important is how are we measuring ourselves against? Or what are we measuring ourselves against? Are we measuring ourselves against our budget? Are we measuring ourselves against our prior performance, whether that's a year, 2 years, 6 months ago, whatever that period is? Are we measuring against that? Are we measuring against our peers? And are we measuring against industry standards? I would argue at some level, every one of those is a yes. They need to be taken into consideration at some level. But what really has to happen is organizationally, we need to sit down and say, okay, days cash on hand, based on where we're at right now, where we've been, and what we have going on, this is going to be the KPI that we're going to strive for. Not that we're going to disregard peers, not that we're going to disregard industry standards, but we're really going to benchmark ourselves against where we were, where we are, and where we want to get to in a given period of time. And that's a very, very important distinction. Again, I don't want to dismiss KPIs altogether. Please don't misunderstand that. They have a role, they have an importance, they have a good purpose to serve for our organizations. But, again, they're not gospel. The other thing I want to point out about KPIs is no one KPI should ever be reviewed in and of itself on a standalone basis. If I told you that my visits are up, but I failed to tell you that my charges are down, my payments are down, and my AR is steady, am I doing well? No, I'm not doing well. But if I just look at visits, I'm doing fantastic. I'm up 10%. Well, yeah, but we're not sending anything out. It's not doing us any good. If I tell you that my visits are up, my charges are up, my payments are down, and my AR is up, but I'm only looking at visits and charges, I'm fantastic. I got this figured out. Well, no, you don't. Your payments are down, your AR is growing like crazy. So again, as we start to think about KPIs and we start to utilize and communicate our performance through the use of dashboards, those are the stories that we have to start to tell. It's never a one metric. It's never we're just going to measure against this. There's always a story to tell. And what's really important, as you'll see as we go through some of the examples, is how are the metrics going to be interpreted by the individuals that are receiving them? So that can be very different depending on the group. If you're talking about your revenue cycle team, they may just want to see something like this. If you're talking about your board, they may want to see something more trended, more detailed, more correlated. It's all about who are we actually talking to, who are we delivering the message to, and how do we know they best receive that message? Is it just data? Is it more graphical in nature? All of that comes into play. Now we've got some sample KPIs up here. I'm not going to go through all of these, but there are a few that I do want to make sure that we do call out. I mentioned before, we can't just take a metric and say, hey, based on this metric, this is how we're doing. I want to start with point of service cash collections. Median percentile greater than or equal to 21.3%. Now, As was mentioned earlier, I work with rural practices all over the country. Point-of-service collections is still incredibly difficult in the rural markets, no doubt about it. And if you tell a rural market today that they need to be at 21.3%, they're going to start updating their resume yesterday. Because they know they're not going to get there for another 8 months, a year. We've got to train the staff to be able to start to have these conversations. Steve's at my window, our kids play ball together. Now I've got to ask him for money where I've never done this before. The community's not used to it. Community's gone there for years. They get their service, they have their claim paid, and then I send them an invoice in 90 days. Hopefully they pay it, maybe they don't. But again, if you just look at that metric and they come in at 12%, you're almost half. You're terrible. You're not doing your job. Well, yeah, but 3 months ago, I was at 8. I've already jumped it to 12. Give me another 6 months. Give me another 8 months. Give me a year. There's a lot of change that has to take place. So again, you can't just take a look at this on a snapshot basis and say you're either succeeding or you're failing based on what you're doing. The other one I want to call out on this slide is the insurance verification rate. If that number is not 100% for every one of your Medicaid patients, I strongly encourage you to make that number 100% for every one of your Medicaid patients. And that needs to be checked multiple times. We all know what's coming. We know patients are going to lose their coverage. We need to make sure when that patient calls up, I call up a clinic and I schedule my appointment and I've got Medicaid, they're verifying that insurance while I'm on the phone. You don't abandon that call until we can say, yes, you do, or no, you do not. If they do, okay, great. Guess what? We're going to check it again when you check in that morning. If they don't, hey, Steve, it looks like your coverage may have turned. Do you have another insurance coverage we can put to this, or can we put you in touch with some of our staff? A lot of organizations have looked at having individuals certified that can help these patients reestablish their coverage. And guess what? That's going to pay for itself in a month. With the amount of people that are going to lose their coverage, if we can get half of those re-enrolled, you've probably already paid for that individual doing what they're doing. So if that number is not 100%, I strongly, strongly recommend that it be made 100%, especially for those Medicaid patients. And again, we're checking it multiple times. Schedule the appointment, I'm checking it. Steve shows up that morning, I'm checking it again. And if we run into issues, I'm trying to schedule that appointment with that certified individual who might be able to get me recertified. Whatever it takes, because we know that impact's coming, we want to try to get out in front of it. Another one that I want to make sure that I call out here is the DNFB. So there are a lot of organizations, I work with plenty of them, that have an automatic 5-day hold before a claim is ever going to go out the door. They want to make sure they don't have any late charges, missed charges, any of that kind of stuff. So again, if I go to my board and I say that, yeah, our DNFB is only at 7 days, well, that's great, but metric's 4.7. Why are you so bad at what you're doing? Well, I'm not. I have XYZ going on. We built in this hold for these reasons. Again, there are stories to tell. And we have to make sure that when we're doing these kinds of presentations, when we're putting forward this kind of data, we know that the audience that we're providing it to is aware of why these metrics are what they are, as well as what they've been historically. Because let's say that is 4.7. Let's say I've got it at 7, but at this time last year it was at 12. That's a rock star performance. I'll take that every day of the week. But if we don't have that, if we don't have that trended data, we've got no visibility to it. If all they're getting is a packet that says, hey, here's our metrics, the board knows what the KPIs are, they see that you're 3 days over, you've got issues. Anytime we talk trended data, Joe mentioned this previously, can't recommend highly enough having at least 15 months worth of data in that trend. Because I want to see not only what's happened in the last 6 months, but I also want to see what happened at this exact time last year. Is there seasonality at play here? Do we have providers that typically take vacation at a given time? All those things are going to come into play. They're going to have an impact on any one of these numbers and probably a lot of these numbers. And so we have to be able to, again, tell that story. And yeah, we're at 7.6 right now, but guess what? Last year at this time, 12. The year before that, 14. You can start to be able to show over time the work that you've done, the improvements that you've made. And that can go a long way towards avoiding confusion about, well, why aren't you hitting industry benchmark? And why are we not even sniffing what the 90th percentile is? Well, because we got a 5-day bill hold that's on so that we don't have to have these missed charges. which is going to result in refiled claims and all this other stuff. You can start to have those discussions and tell those stories. Incredibly valuable for the individuals that are going to receive that information. Now, we're going to go through a few different examples here of what some dashboards can potentially look like. And again, what we have to keep in mind here is how is the information going to be best received by the audience that we're providing it to. So something like this is very simplistic. And that's the other thing about any of this data, any of these dashboards. I think a lot of times when individuals hear the word dashboard, they immediately go to an idea of this big BI tool, right? That has to be out there. It's running automated in the background. It's run through Tableau. It's got all this stuff. And don't get me wrong, I'm a data nerd. I love me some Tableau. I love the drill downs, the playing around. I love everything about it. You don't have to have that level of sophistication. All we're trying to do is tell our story. You can do it in Excel. I did it 2 weeks ago with a little small critical access hospital up in central Iowa. Nothing for miles around. We built a 15-month dashboard that looked at about 16, 17, 18 different metrics that the board said was important, and it's just Excel-driven. So don't let data complexity be a barrier to developing dashboards, to developing some of these graphical representations of data over a period of time. It doesn't have to be that way. You can do something as simple as a chart like this. Now again, if it's me, I would want to be able to see what does that historical trend look like. But for your board or whoever you're presenting this to, maybe they do just want a snapshot. If they do, I would urge you to make sure that you have some of the stories behind these numbers, especially those that are in red. Be able to tell why that is what it is. You know, if we're looking at net days in AR, yeah, it's high right now. Do we have a given payer that we're trying to work with to resolve something? Not that we would ever have denials or anything like that we're trying to work through. What are we trying to do to bring that number down, and can we explain why it is what it is? We also need to tell the story of the wins. Those that are in green. Don't just let our dashboard review be negative. Don't just let it be, here's where we're struggling. Here's our big areas of opportunity. We have to tell those stories of things that we're doing well, especially if we've driven them over time. Let's say, for example, that days cash on hand at 161. Let's say that used to be 80. We need to tell that story. We need to make sure the board, whoever we're telling this information to, understands what we've done to achieve that level. Heat maps are another great way to do this. Can we go through and say, yeah, here's these metrics, here's where we are. Again, you might lose a little bit of the detail here, but if your board likes more of that informational graphic approach, then this could be something that could work really well. Here's the areas where we're doing well. Here's the areas where we're doing okay. We could still stand to improve a little bit. And here's the areas that we really see as our areas of opportunity. Again, it all comes down to that audience. I mentioned the trended data. This is the kind of stuff that I love to see. Anytime I'm meeting with my team and we're talking through performance issues or metrics or anything like that, this is exactly what I want to see. I want to see how we've performed over time, and again, have that ability to go back to a previous period, same time of year, and see how that has changed. If we saw a decrease in visits this month, did we see that same decrease in visits prior year, same month? If so, we can probably explain some of that away. We still need to know the story, but it gives me less heartache than, holy cow, what just happened to our visits? We're down 10%, right? And so we need to make sure, again, that we can be able to walk folks through that and see some of that. Now, I will say I really like the speedometer approach for anything that is going to be a percent of goal perspective. So as we look at this and we look at like our salary and benefits compared to our net patient revenues, where do we want to be? Where have we established our internal KPI, not necessarily could be, but not necessarily the industry KPI? Where have we set our mark, and how are we progressing towards that? Now again, this is something where I would want to have, at least a reference for me to the prior period or prior couple periods so I can tell how are we moving, are we progressing as we should, do we have concerns, all those sorts of things. But again, if the recipient of the information has that more visual mindset, this could be another really good option for you. Same thing here on admissions. Hey, we set this goal. Based on that goal, we are this close to it. We still got a ways to go, but we're progressing in a relatively decent way. Again, it's just about how that's going to be received. Now, again, I mentioned Tableau. I love Tableau. I love being able to get in here and really dive into some of this data. The problem you can run into, though, with something like this is that paralysis by analysis. If you've got that board group or whoever, again, your recipient of the information is, and they just get lost in the page, you're up there presenting, giving your metrics, and you see them just down here like this, and they're just tracing data, trying to figure out what's what. You've got to be careful with something like that. Again, this can give us incredible amounts of information. As we start to look at our market share for this example, this gives tremendous ability for us to take a look at, hey, who is capturing the most patients from our primary service area? Who do we have to be worried about? Or where do we see that our patients are going to? Where are they out-migrating to? The follow-up question then is, well, why are they out-migrating? Is it a service we don't do? Well, then yeah, they're going to out-migrate. There's not a lot we can do about that, but we can tell that story. If it's pneumonia, and we know that we can treat pneumonia in-house, we got something we need to take a look at. Do we have providers that don't trust in our ability to treat that pneumonia? Do we have nursing staff that are spreading bad verbs about how we care for our pneumonia patients? Is there a community perception about how we can do this? We need to make sure that we have that information, but we can't do that unless we have this kind of data. Now again, don't take this kind of data to mean that it has to be in Tableau. It doesn't. You can do this in Excel just as easily. But we have to be able to see what that data is telling us and what it's done over time. Another example here, that, again, showing some of that Medicare market share. Where are these patients going? We know they're from our primary service area, but where are they migrating to? And what are they migrating for? Again, if it's something that we can do, okay, is there a reason that they're going out? If it's something that we don't do, it's probably acceptable, at least for now, but do we want to consider starting to do that service? Can we implement that? Do we have that ability? Same thing here. Now, the bottom right of this screen is a perfect example, and one of the reasons that I wanted to make sure it was in here. That's where it starts to get a little busy. And so, is your audience going to get lost in the information? Or would we be better to, yes, use this as our source data, simplify it, get it down to a more digestible presentation for the audience, and then be able to get it to them, hopefully have them walk away with that information. But with the number of graphs that are down at that bottom right, I do think there's a risk that you could drown out some of those individuals. I'll tell you right now, I would be one of them. If I start staring at all those graphs and trying to figure out which one's going up, which one's going down, I got 3 different greens, which one is which, you've lost me. And so, it all comes down to who the receiver of the information is and how they're going to process that information when it's given to them. This is one that I absolutely love on this piece of market share. Again, it's more simplistic on the bottom right. We can see exactly what our ED and our OBS discharge status trending has been. We can see what our goals are. It's a little bit hard to see, but there's a dash line up there that had our KPI on it. Are we tracking along that KPI? Had a couple times we dipped under, but we came right back up. Again, for that receiver, this is a very clear message about how we're progressing towards the KPIs that we've established. Again, whether those are industry-based, whether those are budget-based, whether those are past performance-based, whatever the case may be, it's a very clear message, and much more clear than something like this could potentially be. And so it could be that we start with something like this, we distill that information, get some of those lower ones off the graph so we don't have them as clouded, and then we end up somewhere like here. Again, what we don't want to do is provide confusion and lack of clarity anytime that we're doing a dashboard. Whether that's for our internal staff, whether that's for our board, senior leadership, whatever the case may be. The goal is simplicity and clear communication. And we wouldn't be doing a presentation without talking about denials. We all know that they're there. We know that they're increasing, and we know that they're a pain. But if we're not actively looking at what our core denial reasons are and implementing proactive strategies to avoid those in the first place, we're doing ourselves a disservice. All you're doing at that point is hitting the nail on the head over and over and over. And every third or fourth time, you're going to hit yourself in the thumb, because it's just that way. We have to understand why we're not being paid for the hard work that we're doing, for the hard work that our providers are doing. And then based on that information, change our internal practices so that we then have the ability to avoid these at all. And how many of you have a billing staff that's responsible for working both AR and denials? A few hands going up. How happy would they be if they had less denials to work and could just do their AR job? How upset would they be if they found out we weren't doing anything and your denials are continuing and your AR's growing and we just keep breathing down your neck about your productivity? If we can change our processes, whether it's related to denials or anything else, based on the data that we have and the KPIs that we've established, we give ourselves a better chance of success long term. And so with that, I'll turn it back over to Joe, start talking a little bit more about dashboards.
Okay, how many of you are using dashboards right now? Are any of the dashboards that we've shared up here similar to what you're using? Yeah? Okay. Any of them that you are using that you haven't seen up here? Any metrics that you're monitoring or trending that you haven't seen? All right. Well, you know, one of the things that I like to just talk about dashboards, I mean, they can be as, you know, basic or as complex as you can make them. And, you know, again, as I mentioned earlier, I think you got to really focus on what drives your business. Not only what drives the business, but also what's happening with your business right now. And we'll go through a few examples here of different dashboards that we've used over the years with different providers based on where they were at in a certain situation. Because I think sometimes you got to focus on certain dashboards or certain metrics in order to make sure that you're monitoring that, in order to make sure that you're addressing the things that are impacting your organization. The other thing I like to say is, as Steve kind of alluded to, you can make these dashboards and data metrics and, you know, tracking all this as hard as you want it to be. I also like to just get back to keep it simple. And if you keep it simple and you focus on those things that drive your business and drive the hospital, drive the health center, drive the clinic, you know, drive the providers, you know, you can really make a difference and not spend a lot of time that you don't have on things that aren't going to help your business move forward. And I think that's real important as we think about this. You know, as I think about, you know, different things that have happened, we did a survey and 89% of the healthcare leaders that we interviewed said that using data to make decisions on a go-forward basis is going to be key for them. And I was talking before, and I was, you know, I alluded to, you know, individuals making decisions on gut reaction. I think I've talked to different individuals, and I've seen where individuals say, well, you know, we made this decision because, you know, we felt that was the right decision. I said, well, you know, what'd you base that on? Well, we just, you know, the board wanted to do this, management wanted to do this, so we did it. And then 2 years down the road, that decision was not a very good financial decision. So organizations and healthcare leaders are making decisions now based on the data that will support that decision. And I think it's important to do that, not only for, you know, longevity of the individual's position, but also, you know, the fiduciary responsibility for the organizations that they serve. If you think about some of the different metrics or some of the different dashboards that organizations are using, I do think that it makes a difference as to what's happening at the organization and which ones they focus on. You know, if you had an organization that was hurting with cash and really was needed to monitor that on a regular basis, is it okay to monitor that on a daily basis, a weekly basis, a monthly basis? I think it is. And I think if an individual organization is struggling in a certain area, they've got to have the mechanisms in place in order to track that so that they can stay on path and not get off path and cause other issues. You know, here's an example of a dashboard that we've used. How many of you have a dashboard like this? Some of you do, right? And so, you know, one of the things I do like about this dashboard is it hits a lot of different variables, a lot of different metrics, and it shows you very quickly where the organization is doing well, where they're kind of doing medium, and where they really need to focus on. But it's something that the organization can look at on a snapshot and redirect and redeploy resources if they need to on a regular basis. And so I have one health system that, they have a dashboard like this, and every single day one of the assistant directors of finance, he looks at this on a regular basis, and he can tell you what's going on in that hospital from soup to nuts. And, I'm like, damn, that's, excuse my language, but I was like, that's impressive. I'm like, you are on top of this. But that's probably a little much for a lot of folks. And that's probably a little much to really find direction unless you have a single FTE that's really focused on this and driving that change. And so, this is a common dashboard that I see for some of the health systems and hospitals that we work with. It hits the financial metrics and really focuses on some of those areas. Steve went over some of the ones, but, are these the things if an organization monitors and follows and compares themselves to, is it going to help them provide direction? One of the things that I haven't said today is you look at all these metrics and you look at some of the peer groups and some of the benchmarks and the percentiles. Am I in the 25th percentile, the 50% percentile? What does that all mean? Well, it doesn't mean a whole lot unless you peel back the onion a little bit. Because as Steve mentioned to before, there was a slide up there where there was 160 days cash on hand. Well, that was better than the metric on that slide. And so some of us may say, hey, that's great. That's great. We got 160 days cash on hand. Somebody else in the room may say, well, if you got 160 days cash on hand, what's it doing in cash? Good question, right? Well, why is it 160 days? Well, did we get a settlement on our cost report? And so we got an influx of cash because we have a settlement? Did we have a big donation? And that came in. So understanding what's behind some of these metrics, I can't stress enough that you kind of got to ask those other questions, those second, third, fourth question, peel back the onion a little bit so that you understand what's going on with the organization as much as what that metric is telling you. And you can get to a lower level, days cash on hand. You can see here that this is being measured on a daily basis, on a monthly basis during each one of those months. And you can see the change in the cash. Well, I can tell you that this organization here was struggling with their cash position. So they were monitoring that on a regular basis so that could help them make decisions as it related to their cash outflows and tracking what their estimated cash inflows were each month. And so that was very important to them. And then also tracking those hospital cash receipts, same way. Well, if you're struggling with cash, you better be monitoring that on a regular basis so that you can make sure that the decisions that management's making and the decisions that the board is making are all in line. Another example here, I do like the examples with the color because how quickly can you focus on those areas? And even though those ones are in green, I still think, initially you can say, yeah, we're doing good there. We don't have to, that's not an immediate focus. I do think if you do ask that second and third question, it could be in green, just like my days cash on hand example. You have to understand why it's in green. So one of the things that I also like to do, or we like to have conversations about is different service lines and understanding how that service line and the metrics within the service line may drive the organization's performance. And so this is just one example of swing bed and the impact of how swing bed impacted or how swing beds drive the financial performance of this organization. And so, to me, if you look at the critical access hospitals and you look at the swing bed programs at those critical access hospitals, if this gets out of whack at a CAH, it could drive a huge payback to the Medicare program or a huge receivable. And I kind of like the theory of, taxes, right? If you think about a cost report as a tax return, you don't want to be overpaid a whole lot during the year, and you don't want to owe a lot at the end of the year. So you want to kind of keep it in a reasonable range as to how much you're going to owe at the end of the year and how much you're going to collect, or how much you have to receive back at the end of the year. Because if you get a huge receivable, that's great, right? You can go to the board and management can say, hey, we got a huge receivable on our cost report. But what happened for the last 12 months? The government used your money. You didn't have that money to put into operations and help the hospital serve the patients in the community that it's serving. And so, again, I think using a dashboard on some of those service lines that drive performance in your hospital are ones that you can really focus on and make sure that you're measuring. Again, another one here as it relates to key performance indicators on physician practices and expectations as it relates to those physician practices, because that's another area that we believe that you need to be monitoring and making sure those physicians are operating at the highest level and making sure that they're keeping up their end of the bargain. How many of you employ physicians? Nobody employs physicians? Some do? Okay. So all of the other physicians are independent practitioners? How many of you that employ physicians, those were independent practitioners before you employed them, and they had a heck of a lot of volume prior to being employed? One or two or three or four? Yeah. So for some reason, when physicians become employed, their productivity goes down. And so, and I'm making a general statement there, so don't shoot me for that, but at the end of the day, I've seen that many, many times. And so having a dashboard that monitors those key things related to physician performance is really important. And it does drive your business. So Steve and I are going to go through a couple case studies. This is where you're going to have to participate. I know we're 50 minutes into this thing, but we will have a couple questions here for you. So we've got a case study here with Surfside Hospital. You can see there that net days in accounts receivable are in excess of comparative data. Point of service cash collections are less than the comparable data. Days in total discharge, not final billed, in excess of comparative data. So, based on these ratios, what do you think is going on here? Pardon me? Yep. What else?
The days in AR could be affected by one payer, one change.
Sure. Yep. Other things? Steve, what do you see?
Well, given that I worked with this client a couple years ago, I can tell you exactly what happened, and you're exactly right. Patient access lost their manager. When that happened, all the monitoring of the patient access functions went out the door. So all of a sudden, we had patients not being verified. Point of service collections weren't being made. We had discharge not final bill actually growing because they no longer communicated with their providers about outstanding charts. At the time that we came in and did our assessment, we had one single provider that had not signed a single chart in over 8 months. 8 months. This clinic had a payer mix of commercial payers of 52%. Guess what that timely filing looked like? Guess what revenue cycle director wasn't there anymore? But it was all because they weren't tracking metrics. Now, you better believe they've got these metrics posted in the clinics now. They've got them posted on a share site now. Everyone goes in and looks at this. There are biweekly meetings around these kinds of things. But it all goes back to, how are we tracking our data? How are we reporting that data? And if we're not tracking it, what could potentially happen to us? And this was a perfect example.
Yeah, I would also add to that, not knowing or not recognizing what just happened at the organization. So when there's turnover, when there's changes, who's following up on that if key people leave the organization or changes happen, a provider leaves, a provider shows up. You know, all of those things I think are really important to make sure that organizations are doing over and above the stats, right? All right, number 2. Steve, you want to run through it?
Sure, we got Shady Acres Medical Center. So they had the following: steady increase in visits and corresponding charges and adjustments, increase in accounts receivable, but payments posted remained flat. So here's kind of a graphical representation of everything they had going. Like we talked before, your visits and charges are in line, your adjustments are relatively in line, payments flat, AR's going up. What we got? One more time. That could be one of them. Denials, absolutely. Claims not going out, absolutely. I'm sorry, one more time. Yep. And so you're exactly right. All those things could be taking place here. But we know we have something going on with the payments and with the AR. We know they're correlated. The question is why. And so this is when, as a management team, it's time to dive into the details. It's time to dive into the data. And I'm just going to pick on one, is Blue Cross, for one reason or another, not paying us right now. And that's driving our flat payments and our increase in AR. For sake, I'll go ahead and mention another one, is United denying our claims. And so again, our payments are flat. Our AR is growing. Because we're not adjusting those yet, we're still going to fight those denials. Please, please fight your denials. But we know it's going to have this kind of an impact. Our visits, charges, adjustments, we might still take our contractual adjustment, but we're going to leave the allowed amount on there as an allowed. So we know that we've still got dollars that are out there. But all of the things that you've mentioned there could lead to a scenario just like this.
All right, number 3, Bayside Medical Center. Majority of denied claims related to diagnosis coding, non-covered services, and patient accounts or access errors. Proactive denials management implemented in January. Dollar value of denied claims sharply decreased following implementation of denials management program.
And if you turn in slides like these to your board, they are going to love you. Because this is exactly what we want to see. I was mentioning previously the proactive denials management, and this is what that program is intended to do. We know that we have claims that are being denied because of diagnoses being inconsistent with the procedure performed. Well, if we have that interdisciplinary team that's coming together that involves providers, that involves coding and documentation, that involves billing, that involves IT, we bring that group together and we identify which specific diagnosis and procedure combinations are causing issues. We provide that education to the providers, to the coders. We make those changes. All of a sudden, we see that decrease. This is exactly what we want to see with those kinds of proactive denials management programs. Same thing for non-covered charges. It's a generic term. We all know it. But there's probably some similarities to why they're being considered non-covered, excuse me. And so what can we do as an organization to identify what's being denied that way, change our processes in one way or another to avoid that denial, and then all of a sudden, payments start coming through as we want them to. The one that I do want to make sure that I touch on here is claim not covered by the payer. How many in the room, just by a quick show of hands, would say the majority of your denials come from your patient access staff? I should see a lot more hands than that, because I'll tell you right now, for almost every organization, it's at least 45% of your denials come from patient access. One of the main reasons for that, does your patient access staff feel like they're involved in the revenue cycle? Some yes, some no. I'll tell you right now, from the survey or from the assessments that we do, a lot of them do not. They feel like they're there checking a box and don't fully understand the impact that they have to the revenue cycle. Don't fully understand that if they choose the wrong insurance carrier, we send that off to them. They send us back a denial in 14 to 30 days. We then have to try to track everything down. We then send everything off again. Well, if it's commercial, we're starting to encroach on that 90 days. Are we starting to hit timely filing? I cannot recommend strongly enough. Talk with your patient access staff about their importance to the revenue cycle and the revenue that our organization generates. I saw a hand back here. Yeah.
Here, I got Mike.
I guess lower hanging fruit that we can, oh, sorry. Lower hanging fruit we can resolve.
Sure.
That you first work on. But in the end, it feels like the part that doesn't get resolved is the ability to say no.
Yeah.
So it's either no to a physician that doesn't get their orders in and they provide enough revenue that we're fearful of saying you can't continue to do certain things.
Right.
The other no is related to radiology procedures, CTs, MRIs that are not always internal, they're external.
Yes.
So it's the promise that the authorization was completed, but in the end it's not. And so you look at the total amount of CTs, MRIs, et cetera,
Yep.
and can you say no because there's a certain number that are not ultimately resolved.
Sure.
But that, to me, is the next frontier, is the ability to say no, and the reality that insurance companies are constantly continuing their increase in authorizations that they're not giving or they're making more and more difficult.
You bet.
But I'm curious what you're finding.
Yeah, no, and I'll add on one thing that you said, and you mentioned the external providers potentially not getting authorizations for imaging. I'll go one step farther. They're getting authorization for imaging, but they're getting it for the wrong CPT code. They're getting it for without contrast. We end up doing it with contrast, and all of a sudden it's null and void, doesn't mean a thing. So we run into those kinds of things all along, and what I would say is very similar to everything that we've talked about here. It all comes down to that communication of the why. And so to your point, at some point we might have to say no. Hey, Dr. Smith, we cannot do those procedures. Here's why, and here's what that means. And yes, that's going to be a difficult conversation. But what I would also recommend is bring a physician champion along with you. Bring another provider that can talk to that individual, provider to provider. Because how many times have we seen administration gives a message to a provider? Another provider gives a message to a provider, and it hits very differently. If you can bring that physician champion along with you to help convey that message to a provider that wants to continue doing something that's just not beneficial to us, that may help in that effort. But you're absolutely right. At some point, we may have to say no. On the external providers, it all comes down to communication. We have to let them know that we are here for you, we are here to serve your patients, but it has to be in a way that we're not just doing charity care. If we don't have margin, we don't have mission. We know that. And so it may come down to training their staff on, hey, when you're ordering that MRI CT, you need to make sure that you're doing it for the right CPT. You need to contact us. Let's talk about this. Make sure that we're getting this right on the front end. Because we all know retro auths are a thing of the past. They are so hard to get, if you can even come close to getting one. And so it all comes down to that upfront preparation, upfront discussion, and planning to make sure that we get the right thing the first time.
All right, well, we appreciate the opportunity to be here, share this information with you. Steve and I will be around to answer questions during the break and whatnot. I know we're at time, so again, thank you for the opportunity to share this information with you.